Let's see what are the common questions asked in arterial disease. We have 10 long essays, but out of that 8 are same question. First question is, what are the causes of leg ulcer, which we discussed previously in previous session. Write in detail about TAO, traumatitis and insurance. Second question is, what is intermittent claudication and peripheral occlusion, PVD, chronic lower limb ischemia, Burgess disease and thromboangiitis ambulatory. And please note this question. This is very tricky questions. A 40-year-old man presented with pain in the right calf while walking for last 6 months. 40-year man has presented with right calf pain. And also he noticed change in the color of second toe of right foot. What can be the diagnosis? The 40-year man can have premature atherosclerosis, or he can also have TAO. No clues has been given by the examiner. But see ABCD. In that he has asked, write a note on management of TAO. So I'll be better off if I write TAO. And also it's 40 years. Normally atherosclerosis is seen more than 50 years, 50 to 55 years. This question is very ambiguous. The examiner has not given clear clues about the diagnosis, but is asking the probable diagnosis. I'll go on with TAO, thromboangiitis obliterans, for this question. Other history, we'll see investigation, management, and all we'll see. Here, look at the sixth question. A 50-year-old hypertensive male presents to clinic with claudication pain over right thigh with gangrene in fourth and fifth toe. In this question, the examiner is clear. The male is 50 years and he is hypertensive, which are the risk factors for atherosclerosis. So I can easily write peripheral artery disease due to atherosclerosis. And also only once acute arterial occlusion is asked, and I'll briefly mention about it. About gas gangrene, once 10 marks question has been asked. We'll discuss the gas gangrene comes under infection. I request you to go through gas gangrene once. About the gangrene and management of atherosclerotic gangrene of the limb, we'll discuss. Define gangrene, how do we investigate and manage the case of diabetic foot. Gangrene we'll discuss. The diabetic foot comes under ulcer chapter. Please go through it. Short essays. Okay, afterwards we'll see short essays. First, let me complete all the 10 marks questions. Okay. Now, the occlusion in the artery can be due to acute cause or due to chronic causes. The arterial occlusion can be acute or chronic. The acute arterial occlusion is most commonly due to embolism. This leads to classical clinical triad of cyanosis, pain, and pale limb. And also the investigation is duplex scan, where we see the blood flow. Due to the blockage, there won't be any blood flow. The treatment of this condition is thrombolysis within 6 to 8 hours. This is about acute arterial occlusions, and other details you can go through in the textbook. The most important disease, the chronic occlusion of arteries, peripheral vascular disease. We are going into it now. Peripheral vascular disease, the disease of peripheral vascular system, where the upper limb and lower limb arteries are involved. In that, most commonly we see upper limb, lower limb arteries involved. And also we saw all the questions are related to involvement of lower limb arteries. The upper limb artery may be involved due to subclavian steal syndrome, and also due to the first rib causing thoracic outlet obstruction and associated conditions in the upper limb. It is not important with respect to exams, so I am skipping that. Now we are seeing the peripheral vascular disease affecting lower limb mainly. The lower limb vessels can undergo chronic occlusion, most commonly due to 3 causes. Those are atherosclerosis, Burgess disease, and vasculitis. The Burgess disease and atherosclerosis related chronic occlusion is asked most commonly in our exams. And Takayasu arteritis vasculitis, it's a medicine question. We are continuing with PVD due to atherosclerosis. Always, we'll first see etiopathogenesis of atherosclerosis related PVD. It is same, not similar. It is same as the risk factors and pathophysiology that we have seen in coronary artery disease yesterday. Now I'll briefly touch upon all the points. The risk factors, we have modifiable risk factors and non-modifiable risk factors. The modifiable risk factors are increasing age, hereditary, the family history, obesity, not family history, sorry. The increase modifiable risk factors are sedentary lifestyle, obesity, hypertension, etc. Non-modifiable risk factors are age. As age increases, the atherosclerotic chances increases. We see atherosclerosis most commonly in old age. That was one of the point in differentiating between Burgess and atherosclerosis. And also gender, a non-modifiable risk factor. Nowadays we can change that also, but still should mention sex of the patient. So the males are affected more commonly than females due to hormone estrogen. Thanks to estrogen, it reduces the incidence of atherosclerosis in females. And also the non-modifiable risk factors are familial, hereditary, family history. These risk factors which lead on to pathological changes like endothelial dysfunction. The endothelial dysfunction is associated with the deposition of lipid underneath the endothelium. Deposition of lipids underneath the endothelium. Along with that, our friend macrophage will come and it will cause the destruction here. On top of it, there is fibrous cap. Fibrous cap is very important. Why we discussed yesterday the difference between vulnerable and non-vulnerable plaque. The fibrous plaque, if it ruptures, it leads to acute arterial occlusion. So this is about pathophysiology of atherosclerosis in brief. So many points are there. I am mentioning it in brief because yesterday we discussed this extensively. The risk factors we saw, pathophysiology we saw. This is about the etiopathogenesis of atherosclerosis leading on to peripheral artery disease. Now, after etiopathogenesis, we'll move on to clinical manifestations of peripheral vascular disease due to atherosclerosis. When the artery is blocked, we see limb ischemia. The limb ischemia may range from intermittent claudication to pregangrenous state, and then at last it may proceed on to develop gangrene. We'll see each of them singly in depth. First, the patient who has atherosclerotic peripheral vascular disease will most commonly present to us with intermittent claudication. The definition of intermittent claudication is very, very important. It's the recurrent crampy muscular pain induced by exercise, which is relieved on rest. I'll repeat. It is the crampy muscular pain associated with activities, exercise, is relieved on rest. This is the definition of intermittent claudication. Now, based on the site of vessel involved, the vessel from aorta to iliac artery to femoral artery, popliteal artery, anterior posterior tibial artery can be involved. Any of these structure can be involved in atherosclerosis. Based on the level of involvement, we have the clinical manifestations. We have the intermittent claudication pain site. So if the patient has aortoiliac block, the patient will characteristically present with Lerich syndrome. The Lerich syndrome has triad of symptoms that is buttock claudication pain. The patient will complain of pain in between the buttocks, and in the buttocks, that is due to ischemia of gluteus muscles. Patient will characteristically have impotence due to reduced blood supply to the penis, and also the patient will characteristically show absence of femoral pulsation due to blockage here. If the patient has iliac block, the patient will complain of pain, claudication pain in the thigh. There won't be any femoral pulse. If the block in iliac, these are the two manifestations. If the block is at the level of popliteal artery, the femoral pulse will be present. The anterior, posterior, and dorsalis pedis pulse will be absent, and there will be claudication pain in the calf muscles. And also, if the block is at the distal vessel, there won't be distal pulse. The dorsalis pedis pulse you will not feel, and also associated with that will have paresthesia in the skin. Also, one point I missed: if the patient has aortoiliac block, will not only have buttock claudication pain, because only gluteus muscles are not ischemic. Here, the thigh muscles and calf muscles will also be ischemic. So, if the patient have block here, all the muscles below it will get ischemia, and the patient will develop claudication pain. This is about the clinical manifestation based on different levels of block. I am discussing about clinical manifestation of ischemic limb, that is intermittent claudication. I discussed the site and the associated symptoms. Now let's see Boyd classification. The Boyd's classification goes as 1, 2, and 3. Boyd's classification 1 says the boy will be walking, good boy, because he is walking. Others are sedentary. So this boy will walk for some distance. After walking for some distance, he develops pain. The distance between start point to the point where the patient develops pain is called claudication distance. And after pain is determined guy, is so determined, he continues to walk. If he continues to walk, the pain will be relieved and the patient will be happy. Now, why this is happening? Here, patients start walking, there is impaired blood flow. The blood flow is reduced to the muscles. So the muscles become ischemic. There is release of lactic acidosis and substance P. I'll mention substance P before lactic acidosis because it is expected from us to answer substance P. So increasing this level will stimulate the nociceptive receptors and cause pain. And if the patient is well determined and he continues to walk, these substance P and lactic acidosis will be washed away, because with walking, the blood flow increases due to many mechanisms which we know in physiology. So due to that, there can be, the patient improves after walking for some distance. This is called Boyd's 1. Classification 1, where the patient, if after walking for some distance he develops pain, the deterministic guy continued walking, the pain will be relieved. What is Boyd's 2? Here also, the patient develops pain after walking for some distance and he is determined and he continues to walk. But unlike this case, the pain will not be relieved. The patient continues to limp and walk. That is Boyd's 2. Here, the proportion of obstruction, the vessel caliber available for blood flow is decreasing as we go from 1 to 3. And in the third, Boyd 3 classification, while the patient is resting, he experiences pain. That is called as rest pain. Pain, pain, pain. He is crying like anything. So in Boyd's 1, we saw the patient walks for some distance, pain, and continued walking relieved. In Boyd's 2, walks for some distance, pain, continued vomiting, not relieved. Limps. In Boyd's 3, the patient has rest pain. So why the patient has developed rest pain in Boyd's 3? The Boyd's 3, the disease has progressed. It has gone to involve the vasa nervosum, which is responsible for supplying the blood to nerves, which is one of the last structure to get involved. The blockage of blood supply to the nerves will cause pain. This is called a pain of dying nerve, the rest pain. So related to rest pain, there is one term called as critical limb ischemia. Related to Boyd's classification 1, there is one term called functional limb ischemia. These may be asked as separate questions, so I will mention what it is. Functional limb ischemia, what it is? We saw in Boyd's 1, what happens? The patient is walking, he develops pain, and upon resting for 10 minutes, the pain will be relieved. So it may occur in both Boyd's 1 or Boyd's 2. I'll repeat, functional limb ischemia is upon activity or exercise, the patient develops pain due to muscle ischemia, and if he takes rest due to pain for 10 minutes, after 10 minutes of rest, the pain relieves. It can be in Boyd's 1 and Boyd's 2, that is functional limb ischemia. If the patient has a rest pain for more than 2 weeks, requiring him to take analgesics, painkiller, NSAIDs for more than 2 weeks, or along with rest pain, if the patient has ulcer or gangrene with ASP or TSP, that is ankle systolic pressure less than 50 mmHg and toe systolic pressure less than 30 mmHg, or ABPI, that is ankle brachial pressure index less than 0.3. I'll explain about ankle brachial pressure index and all while we discuss investigations. It is called as critical limb ischemia. So I told what is critical limb ischemia. Now the rest pain for more than 2 weeks, requiring the patient to take analgesics for more than 2 weeks, or the patient along with rest pain having ulcer or gangrene, with that the ankle systolic pressure or toe systolic pressure, if the ankle systolic pressure less than 50 mmHg, toe systolic pressure less than 30 mmHg, and ankle brachial pressure index less than 0.3, it's called as critical limb ischemia. Critical limb ischemia is the alarm, because should be treating the patient ASAP, or else the patient may continue to develop gangrene. Okay, I hope all of you understood what is critical limb ischemia and about intermittent claudication. Pregangrenous changes that are seen in atherosclerosis, those are edema. When the artery is blocked, it may lead on to edema. The color changes and the rest pain, with or without arterial ulcer. What are arterial ulcer? Due to reduced blood supply, obviously when the blood supply is reduced, the skin which should get the nutrition is not getting, and it goes for necrosis and ulceration. The ulcers seen in case of PVD are punched out, and we don't see any pulsations because of blockade in case of arterial ulcer. This is about pregangrenous changes that we see in case of PVD, peripheral vascular disease. Now, what is gangrene, which is the last manifestation, the end manifestation of peripheral vascular disease? Gangrene occurs when there is severely reduced blood supply to the lower limb. Now, what is gangrene? What is the definition of gangrene? Gangrene is the visible macroscopic death of tissue associated with putrefaction. I am not telling with or without putrefaction. I am telling associated with putrefaction and which may or may not be associated with infection. Now you will get confused. What is putrefaction? What is infection then? Putrefaction is the degradation of the necrotic tissue by saprophytic organisms, which is seen in all the gangrenous tissue. Putrefaction is the degradation of tissue, necrotic tissue, by saprophytic organisms, whereas infections is different thing. Infection is the bacterial invasion leading on to manifestations like pus development and fever, lethargy, all those fever and leukocytosis, all those things. That is infection. We should differentiate. We should clearly know the difference between putrefaction and infection. So in all the gangrene, we can see all types of gangrene, we can see putrefaction. We may or may not see infection. If we see the infection, it is called as wet gangrene. If we don't see the infection, which is called as dry gangrene. The macroscopic death of tissue associated with putrefaction is gangrene. If the gangrenous tissue is mummified, if it is dry, if it is desiccated, it is called as dry gangrene. A clear line of demarcation will be seen in case of dry gangrene between healthy tissue and gangrenous tissue. In case of wet gangrene, there will be superadded infection on top of gangrene. This is commonly seen in arterial occlusion and venous occlusion. This is about gangrene. The clinical manifestation. Now I explained about clinical manifestation ranging from intermittent claudication, pre-gangrenous changes, and gangrenous changes. At last, I'll mention the Fontaine classification of limb ischemia. There are 4 stages. Stage 1, there are no clinical symptoms. The patient is happy. No clinical symptoms. Atherosclerosis is there, but the block is not significant to cause symptoms. In stage 2, the patient experiences intermittent claudication. If the claudication distance is more than 200 meters, it is called as 2A. If claudication distance is less than 200 meters, it is called as 2B. If the patient has rest pain, it's called as stage 3. If the patient has gangrene and ischemic ulcer, it is called as stage 4. This is the Fontaine classification of limb ischemia. These are all the clinical manifestations that we see in case of peripheral vascular disease. Those are intermittent claudication, pre-gangrenous changes, and gangrenous changes. Now we are left with examination findings. What we see in case of examination of peripheral vascular disease and management. Let's see what are the examination findings that we see in case of peripheral vascular disease. The examination findings, how to do an examination, how to do Burgess postural test, how to do Fishick's test, and all venous refilling, capillary refilling. We'll discuss when we have practical exams. The procedure is not important for theory exams, so after theory exams, we'll discuss. While discussing about practical exams, I'll briefly touch upon some points. On inspection of limb, we will see skin changes like atrophy of skin atrophy, loss of shininess, and loss of hair due to chronic ischemia. And we can also see gangrenous tissue on inspection. When we perform Burgess postural test, if the angle is less than 30 degree, it is considered as severe ischemia. Palpation. When we do capillary refilling time, venous refilling time, it will be reduced. And also on doing Fishick's test, that is the crossing over of legs, where we observe for pulsation of the leg, which is the transmitted pulsation of popliteal artery. Physics test, we can confirm to know the involvement of popliteal artery. And also in case of upper limb, we have Allen's test and other tests, which we will discuss while discussing practicals. So on examination, we can see inspectory findings and palpatory findings, Burgess test, Physics test, and delayed capillary and venous refilling. This is about the clinical manifestations of PVD, that is peripheral vascular disease due to atherosclerosis. How to manage this condition? We have investigation and treatment. Under investigation, when any blood vessels are involved, whether it be artery or vein, check for flow of the vessel by doing duplex scan. So the investigation of choice is duplex scan. Then we have some special investigations like ankle brachial pressure index. The term is self-explanatory. We are comparing the maximum systolic blood pressure of ankle to maximum systolic blood pressure of brachial artery. Ankle brachial pressure index. If it is between 0.9 to 1.4, it is normal. If it is less than 0.9, it suggests limb ischemia. If it is less than 0.3, I already told, it is critical limb threatening ischemia. If it is more than 1.4, what it is? It means that it doesn't mean that patient is healthy. It means that the vessel is calcified. And so the blood pressure index is showing variation. It is seen in case of calcified vessels, it may be familial, or the medial calcification in case of chronic renal failure. Why it occurs, we discussed when we discussed CKD. Medial calcification seen in case of coronary renal failure can lead on to ABPI, that is ankle brachial pressure index more than 0.4. And also in case of diabetic patients, we can have ankle brachial pressure index more than 0.4. Since in diabetic patients, we can see ankle brachial pressure index more than 1.4. Now we did an idea. Since ankle pressure is not helping due to calcification, let's go for toe. Then we devised toe brachial pressure index, where toe pressure and brachial artery pressure are compared. If it is less than 0.6, it signifies significant arterial involvement, arterial lesion. And also at last, we have digital subtraction angiography. I am mentioning this investigation because it's being asked as 5 marks question and 3 marks question. What is digital subtraction angiography? Break down each term. Angiography. We are injecting dye into the vessel and visualizing. Why the term digital subtraction? Because along with injecting and dye and visualizing the artery, we are using the technology, the computer, to subtract the surrounding tissue of the vessels. So it's called digital subtraction angiography. The advantage of this procedure is the visualization of the arteries are increased, obviously. And the disadvantage, as always, is cost factor. So we discussed about investigation seen in case of PVD, that is duplex scan, ABPI, TBPI, and then digital subtraction angiography. Let's go on to discuss the treatment done in case of PVD due to atherosclerosis. What is the treatment of this condition? First, we should address the primary cause which are leading on to atherosclerosis. Treat diabetes and hypertension. Diabetes and hypertension, we know, is the risk factor for atherosclerosis. Then, definitive management. What to do for already developed plaque? We can do direct anatomical reconstruction. That is iotoiliac and alterectomy. It is reboring or this obliteration procedure useful for type 1 disease. Diseased intima plaque with thrombosis removed with arterotomy along with entire length, which is closed later using 50 or 40 polypropylene continuous suture. What is done here? We'll remove the plaque, diseased plaque. And then after removing this, we perform arterotomy by how to remove this? The plaque is removed by performing arterotomy, that is opening up of vessel. We will take out the plaque. Then we'll close this by using continuous suture. This is iotoiliac and arterectomy. Next we have iotofemoral bypass. This iotofemoral bypass graft. It is the gold standard surgical procedure in type 1 and type 2 disease, where long-term patency rate is 70 to 80%. 70 to 80%. Here the woven Dacron graft is used. What happens in iotofemoral bypass graft is the diseased artery, removing it, and we are placing synthetic Dacron graft in place of this removed artery. This is called iotofemoral bypass graft. The indirect extra abdominal bypass also we can do. It is quicker and technically easier and suitable to patients who can't tolerate analytical bypass. Also, the non-operative catheter-based endovascular procedure are most important procedures which are done nowadays. Non-operative catheter-based endovascular procedure. Here, if the stenosis is less than 5 centimeters, the percutaneous transluminal, the probe is passed, and then we'll remove the plaque. Sorry, not remove. As in done case of angioplasty in case of coronary artery disease, we will go inside. The plaque will be there. We'll take balloon. We will inflate the balloon with suitable pressure, and then we'll establish the patient patency of vessel. Following that, we'll place the stent and give the patient antiplatelet drugs after that. So this is about the management of atherosclerosis disease in case of iotoiliac occlusive disease. All this which I mentioned is for iotoiliac occlusive disease. What to do in case of iotoiliac occlusive disease? Before that, let me mention what is type 1, type 2, and type 3. In type 1 iotoiliac occlusive disease, the distal aorta and common iliac artery is affected. Type 1, the distal aorta along with common iliac artery is affected. So what to do? In type 1 disease, we do iotoiliac endarterectomy. It is suitable compared to ioto. It is suitable in this case. We'll go inside, perform arterotomy, remove the plaque, place the, and then not place the stent. Sorry, remove the plaque and then suture with continuous suturing. Then we have type 2 disease where there is widespread abdominal aorta and iliac vessel involvement. Here the disease is severe. There is widespread atherosclerosis of distal aorta and then iliac vessels. What to do in this case? We can't help, man. The disease is extensive. So we just remove this and place a synthetic graft, Dacron graft, that is iotofemoral bypass graft procedure done in case of type 2 disease. In type 3 disease, what happens? In addition to this, we'll see infrainguinal artery getting involved. That is type 3 aortoiliac occlusion. Let me summarize these points for you. We saw the management, definitive management in case of aortoiliac occlusion, where in the type 1 disease, where distal artery along with the common iliac artery is involved, the aortoiliac endarterectomy is done. In type 2 and type 3 disease, where there is extensive involvement, will perform aortofemoral bypass graft surgery, which ensures 70 to 80% patency in 70 to 82% cases. What we do here, we'll remove the involved part of the artery and then we'll place the Dacron graft. And the the latest procedure is catheter endovascular procedure, similar to PTCA, coronary angioplasty. We go inside, inflate the balloon, and then place the stent and continue the patient on antiplatelet therapy. This is the definitive treatment which is seen in case of aortoiliac obstruction. Now, what is the definitive treatment if the infrainguinal artery is occluded? In that case, the definitive treatment is the popliteal artery below the knee. 1 minute, let me write down. Infrainguinal arterial system. In case of involvement of infrainguinal arterial system, if the popliteal artery below knee is patent, femoropopliteal bypass is the ideal procedure used. So what the textbook is telling is, one femoral artery, popliteal artery, anterior and posterior tibial artery. So if the below the popliteal artery, the vessel is patent, can perform femoropopliteal bypass this and establish patency. Femoropopliteal bypass surgery. Also, we can do profundoplasty to improve collateral circulation through profunda femoris, that is bleed deep femoral artery. It is the other procedure. Also, we can do profundoplasty. So this is all about the PVD, peripheral vascular disease due to atherosclerosis. I'll summarize the treatment once again. Treat the primary cause first, diabetes, manage diabetes and hypertension, followed by definitive surgery. That is, if the aortoiliac segment of artery is involved, if it is type 1 disease where distal aorta with common iliac artery is involved, perform aortoiliac endarterectomy. If it is type 2 disease and type 3 disease, perform aortofemoral bypass graft. And also we can do the latest procedure, catheter endovascular procedure. If the infrainguinal arteries are involved, we perform femoropopliteal bypass and profundoplasty. I hope you have understood all the things under atherosclerosis, PVD due to atherosclerosis, radiopathogenesis, clinical manifestations, and then investigations, treatment, examination, finding. First, let's discuss about definition of Burgess disease. Burgess disease, it's the young disease, the disease seen in young patients, which is characterized by segmental, progressive, occlusive, inflammatory disease involving small and medium vessels with superficial thrombophlebitis. And often may present as Raynaud's phenomena along with neutrophil and giant cell infiltration. I'll give the short version of it. Burgess disease is the disease seen in young patients between 20 to 40 years, associated with progressive inflammation Progressive segmental inflammation, segmental blip, because only a segment of artery will be involved, followed by the disease-free zone, followed by segment of artery involvement. So it's a disease of young occurring between 20 to 40 years involving segmental, medium and small vessels. Note this point: medium and small vessel are involved in Buerger's disease, whereas large vessels are involved in case of atherosclerosis. In atherosclerosis, we saw aorta is involved, the femoral artery is involved, popliteal artery is involved, and also the distal artery may also be involved. But Buerger's disease will not involve femoral aortic artery, iliac artery. That's large vessels is not involved. Only small and medium vessels involvement is present, along with superficial thrombophlebitis. Now, what is the risk factors of Buerger's disease? Risk factor. What is the pathophysiology of Buerger's disease? The Buerger's disease, it's also called as smoker's disease because it's seen mostly in people who smoke. The carbon monoxide and nicotinic acid present in the smoke in a genetically susceptible individual, it causes the inflammatory cell attack against type 1 and type 3 collagen, which are present in the blood vessels, which are present in the superficial vessels, medium and small arteries, and also connective tissues around the nerves are also involved. So, in case of atherosclerosis, only large arteries was involved. Here, the medium and small arteries, veins, and nerves are involved. Please note this point. There is a significant difference in pathogenesis between atherosclerosis and Buerger's disease. The smoking leads to immune attack to the type 1 and type 3 collagen, which leads on to inflammation of artery, vein, and nerves. The medium and small arteries, when involved, it leads to development of collateral. Always the body tries to compensate. But if the patient continues to smoke and the inflammation continues, these collaterals will also be involved. If only the medium and small vessels are involved and collaterals are not involved, it's called as compensatory PVD, that peripheral vascular disease. If along with small and medium vessels, the collaterals are also involved, it's called as decompensatory PVD. And with the time, the involvement of medium and small vessels, if the patient continues, he is not quitting smoking, he afford to lose his limb, but he doesn't want to quit smoking. With the time, the large vessels may be involved. This is about the pathophysiology of Buerger's disease. Smoking, leading on to immune attack to collagen type 1 and type 3, leading on to pan-arteritis, segmental progressive pan-arteritis, along with inflammation of nerves and veins. And then we saw compensatory PVD and decompensatory PVD, which can be seen when we do angiography and Doppler studies. If the collaterals are not involved, it's compensatory. If the collaterals are involved, it's decompensatory PVD. Following that, with time, large vessels may be involved. This is about pathophysiology of Buerger's disease. Now, quantify smoking as a risk factor. The smoking index should be more than 300. If the patient has started smoking 1 week back and he develops, let's say he's 55-year-old, he has started smoking 1 week back because of his close friend recommending him to take, or any other life reasons. And if that 55 years patient develop Buerger's disease and he comes and tells you that I developed, he presents to you with claudication pain, you can't tell that smoking is the risk factor because he's more than 55 and also he has just started 1 week back. Now, how to quantify that smoking is the risk factor is by calculating smoking index and pack year index. What is smoking index? Smoking index is number of years of smoking into number of cigarettes smoked per day. If it is more than 300, then smoking is considered as risk factor for Burgess disease in the particular patient, the given patient. If the pack year index, that is number of years of smoking into number of packets of cigarettes smoked per day, is more than 40, then smoking is the risk factor in the given patient. We will discuss the Chianoya criteria for Burgess disease. For you to tell the patient is suffering from Burgess disease, he should use tobacco, and it occurs most commonly in male only due to genetic reasons. The disease starts before 45 years. It's characteristically seen between 20 to 40 years of age. The distal extremity involved first without embolic or atherosclerotic features. I told you during etiopathogenesis, first medial and small vessels are involved, then followed by large vessels. Then the patient should not have diabetes mellitus and hyperlipidemia, which are the risk factors for atherosclerosis. With or without thrombophlebitis. I mentioned you, the patient can have thrombophlebitis because of inflammation of nerve. Inflammation of vein. This is about the etiopathogenesis and Chianoya's criteria for Burgess disease. Now, this pathophysiology will lead on to the clinical manifestations. The clinical manifestations are very simple. It is a characteristically occur in smoker with 20 to 40 years. The clinical manifestations are same as we saw in atherosclerotic PVD, because in both the cases vessels are being occluded and there is ischemia. The patient will characteristically have intermittent claudication with feeble pulse, that is, you may have voids 1, 2, or 3. And with time, the patient can also develop gangrene, that is dry gangrene, wet gangrene, anything. And also on clinical examination, there will be feeble pulse. Characteristically, in early of the disease, the distal pulse will be absent, followed by involvement of proximal arteries and loss of pulse. What is the management of Burgess disease? The investigation and treatment. Investigations are Doppler study. We know on Doppler study we can identify whether it is compensatory or decompensatory. The details of which is not required. On ABPI, the ankle brachial pressure index, if it is less than 0.9, same here, it will be considered as limb ischemia. If it is less than 0.3, critical limb ischemia. Also, we have other investigation called as transbrachial angiogram. See, in this Burgess disease, at the last stages, the large arteries will be involved. If the femoral artery is involved, it is fibrosed and it is not appropriate for doing investigation by introducing some dye and all through the femoral artery. So we can perform transbrachial angiogram, meaning through the brachial artery in the upper limb, we pass the probe and we'll perform angiography of the lower limb vessels. And also at last, we have intravascular USG, meaning we are passing USG probe inside the blood vessels and we are inspecting it. And also we can do digital subtraction angiography, as we mentioned in atherosclerosis disease. The other important and characteristic investigation which can be done but not done is biopsy. We perform biopsy of nerve, vein or artery, we can see panarteritis and inflammation of nerves and veins because of this process. So this is about the investigation done in case of Burgess disease, that is Doppler study, which is the investigation of choice, ABPI, transbrachial angiogram, and intravenous ultrasonography, and then biopsy. Now, how to treat this patient with Burgess disease? The treatment of Burgess disease is first quit smoking. or you will lose the limb. Advise the patient to quit smoking, or else we can give psychiatric consultation for assistance from psychiatrist, because it's very difficult for even anyone to live their addictions. After quitting smoking, we can give some drugs for managing this Buerger's disease. The most important drug is xylostazole, which is phosphodiesterase inhibitor, given as 100 mg BD. And also we can give aspirin, low dose aspirin 75 mg OD, or clopidogrel 75 mg. The other interesting therapy is vascular endothelial growth factor, VEGF. We can give intramuscularly, we can inject vascular endothelial growth factor and stimulate angiogenesis. We saw quitting smoking and drug therapy. Next up in the line, we have limb care. So we'll suggest the patient Buerger's position and exercise. Regular graded isometric exercise up to a point of claudication improves the collateral circulation. In Buerger's position, head end of bed is raised, foot end of bed is lowered to increase circulation. So, in limb care, we have three things. The two things we discuss now. The first one is Buerger's exercise, that is regular graded isometric exercise. I hope all know what isometric exercise is. To a point of claudication until the patient develop claudication. Why it's done? It's done to improve collateral circulation. This is about Buerger's exercise. We have Buerger's position, where head end of the patient is raised and foot end is lowered. It improves circulation in the lower limb due to gravity effect. And also, last in limb care, we have care of feet, that is chiropody. Care of feet. Exposure of feet to cold and warm temperature should be avoided, and minor trauma should be avoided. The footwear should be selected carefully. It is better to walk with socks. It's better to use socks with footwear. Heel raise by raising the heels of shoes by 2 centimeters decreases the calf muscle work to improve claudication. So under foot care, we have use of socks, and also minor trauma. The patient should avoid minor trauma associated with this. In the chappals, the heel end should be raised by 2 centimeters so that the work of calf muscles decreases and it improves claudication pain. So we discussed quitting smoking, drug therapy, and limb care. Last, we have chemical sympathectomy. What is chemical sympathectomy? Sympathetic chain is blocked to achieve vasodilation. We all know that which system is responsible for vasoconstriction, that is sympathetic system. If we perform chemical sympathectomy, meaning that we inhibiting the function of sympathetic system, there will be vasodilation and improved circulation. It is achieved by injecting local 1% xylocaine paravertebrally. We inject 1% xylocaine in front of lumbar fascia to achieve temporary benefit. This is temporary. Then we have permanent chemical sympathectomy. Permanent chemical sympathectomy is achieved by injecting 5 ml of phenol with water under C-arm guidance. Feet will become immediately warm after injection due to sympathetic blockade. The problem are there is possible risk of injecting phenol into inferior vena cava and aorta. Also, there is possibility of spinal cord ischemia. So we discussed chemical sympathectomy, where we have two methods: temporary and permanent method. In temporary method, paravertebrally we inject 1% xylocaine to achieve some temporary benefits. To have permanent benefit, we have 5% phenol with water injected paravertebrally. This procedure has its own complications. What is the treatment? What can be the surgery that we can do in this patient? First one, here we have omentoplasty. Omentoplasty, it helps to, meaning we are taking omentum from the abdomen and we are placing it in lower limb. It helps in improving blood supply in the limb. Then we have profundoplasty. What is profundoplasty? Due to blockage of profunda femoris, it is done in case of blockage of profunda femoral artery so as to open more collateral across the knee joint. Profundoplasty we also do in case of atherosclerotic disease, where the block in profunda femoral artery is removed so that the collaterals below the knee joint get adequate blood supply. Profundoplasty. And then we have lumbar sympathectomy. Here we discuss chemical sympathectomy, or else we can surgically remove the lumbar sympathetic chain in order to cause vasodilation and improve clinical symptom of the patient. At the last result is if the patient has gangrenous limb, large vessel is involved, severe disease, at last we can do amputation of limb. Other method is we can do Ilizaro method. Ilizaro we know it's a bone lengthening method. Ilizaro method. In that we perform osteotomy and then we distract the bone with using external fixator, Ilizaro external fixator, so as to cause neoangiogenesis. Here we will be having external fixators. Now here the blood supply increases, neoangiogenesis. Not commonly done. So this is about Burgess disease. What is the treatment done in case of Burgess disease? Quit smoking, pharmacotherapy, limb care, chemical sympathectomy, the temporary and permanent one, the surgery, omentoplasty, profundoplasty, and lumbar sympathectomy, at last amputation, and rarely Ilizaro method. This is all about Burgess disease. Done with all the 10 markers. All the 10 markers we are done. Acute arterial occlusion also we did partially. Let's put it green mark. And also intermittent claudication, all know what is it. Investigation in peripheral vascular disease, non-invasive we discussed. Digital subtraction angiography we discussed. Burgess disease we discussed. Raynaud's phenomenon. Raynaud's disease is remaining. Intermittent claudication done. Rest pain done. Ankle brachial present is done. Arteriography, it's asked only once as 3-mark question. I request you to go through it. Digital subtraction angiography done. Lumbar sympathectomy done. Gangrene causes done. Diabetic foot comes under ulcer. Please go through it. And Einham. What is Einham? Einham is dactylosis spontanea. What is dactylosis spontanea? If the patient has vascular insufficiency to the fifth toe, Einham occurs most commonly in the fifth toe. There is vascular insufficiency to the fifth toe. The fifth toe will undergo spontaneous amputation. It is called as Einham. It can be seen in peripheral vascular disease, diabetic patients, and many other conditions. This is about Einham. You get a 3 marks question, you can manage it. So we are done with Hainham. And then we have Raynaud's phenomenon or Raynaud's disease at last. Let's see it. So what is Raynaud's phenomena? Definition of Raynaud's phenomena. Raynaud's phenomena is an episodic, localized vasospasm. Episodic meaning it's not occurring always, it's seen as episodes. Localized meaning only a part of vessel is involved. Vasospasm is present. Of not large vessels, not medium vessels, of small vessels. Hands and foot. Leading on to temperature and color changes with sequelae of clinical features called as Raynaud's syndrome, which has initially, so this is Raynaud phenomena leading on to clinical manifestations called as Raynaud's syndrome. Raynaud's phenomena leading on to Raynaud's syndrome, which has initially pallor due to vasospasm followed by cyanosis. Why? Because with after vasoconstriction and reduced blood supply, the deoxygenated blood increases, cyanosis, leading on to cyanosis. Last, the cyanosis, when there is ischemia, it leads on to release of increase in H plus ions, increase in CO2, etc., which causes in the capillaries and small vessels, which will cause dilatation of vessels due to these substances. There will be dilatation of blood vessels. We all know this. Even in the capillary, there is increase in H plus or CO2, anything which causes pre-capillary sphincter opening, and it increases circulation. So at last, the patient will have congestion, red. These are the three phases of Raynaud syndrome, that is pallor, cyanosis, and congestion or reactive hyperemia. What are the causes of Raynaud syndrome? Why Raynaud syndrome occur? The Raynaud's disease. Raynaud's disease occur most commonly in females, and it's usually bilateral. It occurs in upper limb with normal periphery. Periphery is normal because the medium and large vessel is not involved. Due to angiosperm of small blood vessels, symptom can be precipitated with, and other thing, please note the symptoms of Raynaud phenomena can be precipitated with exposure of hand to cold water. Now, what is causing is most commonly seen in females, usually bilateral disease. What is the cause? What is the cause? The most common cause is working with vibrating devices like pneumatic road drills, the drill workers, the woodcutters, the fishermen traveling in machine boats where they'll place the hand in the vibrating boat. Fisherman in vibrating ship. So if the patient associated with exposed to vibrating activities like road drilling, wood cutting, or fishermen placing their hands in the ship which is vibrating, it is associated with Raynaud's disease. The collagen vascular diseases like scleroderma, rheumatoid arthritis causing vasculitis can lead on to Raynaud's disease. We have seen while studying rheumatology in medicine. And other causes are cervical rib and Burgess disease. Yes, Burgess disease we saw. We can see Raynaud's phenomena sometimes. And it is often associated with Crest syndrome. What is Crest syndrome? That is calcinosis cutis, Raynaud's phenomena, esophageal defect, sclerodactyly, and telangiectasia. We'll see in medicine afterwards. So we saw in Raynaud's disease, it is most commonly seen in case of vibrating people who are exposed to vibrating devices, or in case of collagen vascular diseases like rheumatoid arthritis, scleroderma, in patients with Burgess disease and all. So we have two types of Burgess disease, that is primary Raynaud's phenomena. It's an idiopathic vasospastic disorder without underlying identifiable cause. Usually there is no significant pain in primary type. It's due to increased sensitivity of alpha 2 receptor to norepinephrine, or due to decreased NO or endothelin 1. Increased serotonin and thromboxane commonly seen in females. We have two types of Raynaud's phenomena, that is primary and secondary. In primary Raynaud's phenomena, we can't attribute the Raynaud's phenomena to any disease. Most commonly, there's increased receptivity, increased sensitivity of alpha receptors to norepinephrine. In case of secondary disease, we already see there it's associated with Burgess. If the Raynaud's phenomena is associated with Burgess disease, collagen vascular disease, rheumatoid arthritis, etc., etc., it is called as secondary Raynaud's phenomena. Primary Raynaud's phenomena, no identifiable cause. Secondary Raynaud's phenomena, secondary to other disease. I hope it's clear. The clinical manifestation, we know there is pallor, which is called as syncope of hand also, dusky cyanosis due to asphyxia, and also at last reactive hyperemia leading on to congestion, redness. Please note when the patient presents with these symptoms, the peripheral pulse will be normal peripheral pulse. We all know this. Should not have any doubts. What are the investigations done in case of Raynaud's phenomena? The type of Raynaud's phenomena can be identified by angiogram of hand, that is MR angiogram. We can do MR angiogram or duplex scan. Why we are mentioning the type can be identified? Because in case of primary Raynaud's phenomena, where there is no identifiable cause, there the vascular changes like vasculitis changes, which are seen in rheumatoid arthritis and Burgess disease, is not seen. So on MR angiography, we can find out whether it is primary or secondary Raynaud's phenomena. Investigations are X-ray of the pulse, antinuclear ANA assay, because to rule out any secondary causes like A and scleroderma. There is assessment of segment blood pressure gradient from brachial form. Okay, we can assess the segmental blood pressure, and other routine blood investigation also we can do routine blood investigations like lipid profile, blood sugar levels, and all. How to treat Raynaud's phenomena? Treatment of Raynaud's phenomena. First, if there is identifiable secondary cause, treat it. The patient is suffering from RES scleroderma, treat the patient with steroids or NSAID, DAMAD accordingly. Avoid precipitating factors like protection from cold or using proper dresses. And then we can use pentoxifillin. We can use low dose aspirin, 75 to 100 mm and 100 mg per day OD dose. We can also use nifedipine, calcium antagonist, CCA, calcium channel blockers, nifedipine, TMG. Because here the cause is vasospasm, we can relieve the vasospasm by giving nifedipine. Steroid may be useful in secondary causes. Secondary causes, steroid is useful. I already mentioned that point. Also, AC inhibitors, nitrates, endothelin inhibitors, prostaglandin potent vasodilators, antiplatelet drugs, all are tried in research, can be tried in different stages of diseases. The cervical sympathectomy is used for non-healing digital ulceration, not very beneficial in Raynaud's syndrome. Okay, we'll leave this point. Localized digital sympathectomy by stripping off the adventitia of the distal vessels, often with the radial or anterior resection of Henle, a branch of ulnar nerve in the forearm. Sympathetic and ulnar is said to be affected. Okay, we can do one more procedure. Here we saw there is increased alpha receptor receptivity to norepinephrine. So we can treat this disease by removing sympathetic innervation. Since distal vessels are involved, we can perform section stripping of the tunica adventitia of radial artery or ulnar artery, or the a branch of ulnar nerve which lies along the ulnar artery called nerve of Henle can be resected, which is responsible for sympathetic innervation of hand. So we saw the treatment of Raynaud's phenomena. Treat the secondary cause, avoid cold by using proper dressing, low dose aspirin 75 to 100 mg per day, nifedipine calcium channel blocker, and sympathetic blockade by stripping off the tunica adventitia along the radial artery or ulnar artery, or resecting nerve of Henle, the branch of ulnar nerve. So this is about the clinical manifestations, idiopathophysiciology, investigation and treatment of Raynaud's syndrome. By this, we are successfully ending the arterial disease